Okay, my voice is clear and screen is clear to you.
Yes, sir.
Okay, okay. Almost everyone joined. Okay, so let's start. So first, yesterday we had discussed about the vasculitis, in which we have discussed about the large, medium, and the small vessel vasculitis. And the one question we had asked that based on Hinox colon vasculitis, that is HSP. So this is what we have the guaic positive stools. If you see the hidden stool, hidden blood in the stool, so that is means we have the guaic positive stool. Okay. So after that, we having the another disorders like Rocky Mountain spotted fever, like epidemic typhus, and the systemic lupus erythematosus. We know that is the type 3 hypersensitivity. That is the type 3 hypersensitivity, and it includes the butterfly shaped rashes. So we will discuss in I think in therapy or maybe in the pediatrics later on. Then we have the idiopathic thrombocytopenic purpura. What is the mean by idiopathic? The idiopathic means unknown. The cause is what? Unknown. We don't know about the particular cause. And thrombocytopenia, we know that what the platelets is known as our thrombocytes. The platelets is known as thrombocytes. So if we will be having the decrease of what thrombocytes level, so there we call this as the thrombocytopenia. So that is idiopathic thrombocytopenic, and the disorders, that is immune mediated destruction of the platelets. So that is called the idiopathic thrombocytopenic purpura. So let's discuss this. The second one we would be having, that is the idiopathic thrombocytopenic purpura. Okay, so this is what that the ITP. We have the immune mediated destruction of what? Platelets. There, who will destruct the platelets? By the immune systems. Our immune system will be there. That's why we call this the immune mediated. So there will be the immune mediated destruction of platelets and inhibition of platelets, and the platelets released from the bone marrow. From the bone marrow by which cell? By the megakaryocytes. So there will be no platelets will be released from megakaryocytes. So that will be inhibited by the immune system from megakaryocytes. So because the megakaryocytes, they are the major cells that will release the, or that you can say that will be converting into the platelets in the blood. And the megakaryocytes, these are the cells that is present in the where? In bone marrow. So what you are going to see in this condition, if we will be having the decrease of the platelets, so of course there will be the bleeding. But in idiopathic thrombocytopenic purpura, we will be having the mucocutaneous bleeding. We will be having mucocutaneous bleeding will be there. And if we are going to check about the peripheral smear, the peripheral smear means we will take out the blood samples, and then we will check out the peripheral smears. We will check about other cells. We will check about the neutrophils and neutrophil, eosinophils, other WBCs, but that will be present. So this is known as the normal peripheral smear will be normal in this condition. Because in case of ITP, there will be isolated thrombocytopenia will be there. There will be the isolated thrombocytopenia, means only platelets level will be decreased. Thrombocytopenia. In these conditions, and of course, now we will be having the inhibition of the platelet from the megakaryocytes. Now when there will be the inhibition will be there, so the megakaryocyte will become angry, and when the megakaryocyte will become angry, it will become giant. So there will be the giant megakaryocyte. There will be the giant megakaryocyte will be there in bone marrow. And remember that in bone marrow, we can be having the normal or increased number of megakaryocytes. So that you have to remember. You know, it doesn't mean that it will be always will be increase in the megakaryocytes. They can be the normal in the number. Okay. And isolated thrombocytopenia, usually the platelet level will be less than 20,000. That will be less than 20,000. And remember that one more thing here, that we would be having the primary ITP, and then primary ITP, this is also known as AKA. AKA means also known as, also known as. So this is also known as our Verhoeven's disease. This is also known as our Verhoeven's disease. Okay, so this is what, that is our primary ITP. In the primary ITP, basically we will be having the mucocutaneous bleeding, normal peripheral smear, isolated thrombocytopenia. The platelet level will be decreased less than 20,000, and there will the giant megakaryocytes will be there. Okay. Then we have the post-streptococcus glomerulonephritis. We will discuss, I think, after this. Then we have the question number 2. A young man has a painful induration in the peripapillary regions. Yes, 1 second. After that, we will be having a 9-year-old girl with a history of intermittent wheezing. What is the wheezing? The wheezing means, like you can say, one sound. The sound that the patient will feel while on inspiration or expiration. So it can be the inspiratory wheezing or it can be the expiratory wheezing. In most of the conditions, you will get the expiratory wheezing while during the expiration. For several years is brought to the pediatrician. The child has been taking no medication for some time. Physical examination reveals agitation and perioral cyanosis. Intercostal and suprasternal retraction are present. So these are what? There are some muscles are there, intercostal muscles and the suprasternal muscles. The breath sounds are quiet. Quiet means like there is no sounds are you are hearing, and wheezing is audible bilaterally. The child is admitted to the hospital, so appropriate intervention might include all of the following except. So first of all, this is not a good question as per se. So, but we have to solve the question. So first of all, you have to see what are the age of the child. That is the 9-year-old girl. Then you see the patient is having some kind of a wheezing and having agitation as well, and there will be the bluish discoloration, cyanosis, bluish discoloration around mouth. So what you have to see in this patient, and there is wheezing. So basically there can be some obstruction can be there, will be there. So it can be what? Asthma or upper airway obstruction. Asthma or upper airway obstruction. Because in this condition we will feel some kind of the wheezing will be there because of the obstructions. So let's go through the options. You can administer the supplement oxygens. So oxygen will be given when the patient will be having the desaturation. So of course that will not be the answer. Then we can be having prescribed intravenous aminophylline. The aminophylline are what? They are the bronchodilator. These are the bronchodilator. Okay, but they are given intravenously. Then we have the prescribed the nebulized metoprolol, and this is what metoprolol. It is also known as the ocyprenolin. It is also known as the ocyprenolin. Okay, and this will also be not be given. And then we have the corticosteroid. The corticosteroids are what? They will reduce the mucus secretion because this patient doesn't have any kind of the mucus. So this is the reduce the mucus secretion. Okay. So what is the appropriate intervention that might include all of the following except? Yeah, sorry. All these things we can apply in these patients. All because and this is not because of the priority. If we will be having the priority, like which one will be given, we will firstly we will give the bronchodilator. Then because oxygen is not so much requirement, but this is in the options, we can give this to the patient. If we don't have any other drugs, still we can give the oxygen. So the best drug that we can't give in this patient, that is what our prescribed nebulized cromolyn sodium. Why the cromolyn sodium? Because it inhibits the histamine release. That's why you're saying that this is not so good question, because it inhibit what? Histamine release. The histamine will not be released from the mast cell. Histamine released from mast cell. It will inhibit the histamine release from the mast cell, and that will lead to the bronchoconstrictions. That will lead to what? Bronchoconstriction. That's why we will not prefer this nebulized cromolyn sodium in this patient. Okay. Next is also the same, not so good questions. Routine examination child with a history of the bronchial asthma reveals your most of the question that you will be find unusual question you will find in the gynecology. Okay, there will be some like you can say controversial questions are there that you will find in the gynecology. Then we have the fourth routine examination of the child with a history of the bronchial asthma. So this patient is what having the history of the bronchial asthma is there, but histamine inhibitors is good in this case. Yeah, but still we will because it inhibit the histamine release and finally it will lead to the bronchoconstriction. That's why we will not give this drug. Okay, basically idea of this question that you have to understand the all the options here. Don't go through the questions what intervention you can include or not. The main thing that you have to understand all the options, like what are the cromolyn sodium, what are the corticosteroids, what is the aminophylline, and what are the oxygens. The basic idea of these questions, and the next question is also the same. Then routine examination of the child with a history of the bronchial asthma reveals the arterial pressure is 140/90. The most likely cause of the hypertension is, so this type of the questions doesn't come for now. This is the like very old question and unusual question again. Dekho, now in this patient is what we would be having the high blood pressures. So will high blood pressure, it means it can constrict and narrow blood vessels in kidney as well. Okay, let's suppose in kidney it can constrict the all the vessels. So high blood pressure, it means our basically our blood vessels will become constrict and they will become narrow. So if high blood pressures will create what? Constriction and the narrowing of the blood vessels in the kidney. So what will be there? What will be there? There will be decrease of what? Blood flow. There will be the decrease of the blood flow, and there will be kidney will stop working. Kidney will stop working in valve condition. Okay, there will be the improper kidney function will be there. And if their kidney or that is a decrease in the blood flow, that decrease in the blood flow will, what will do? It will cause a retention of sodium and water. And there will be the hormonal release as well. Okay, and again that will constrict what? If this retention of the sodium and water will be there, that again will come. What it will do? Again will increase what? Because there is the sodium and the water. The sodium will is main factor is responsible for the high blood pressure. So again that will increase what? High blood pressure. So the most likely cause of hypertension here in this condition that is renal disease. There is nothing related to the history of bronchial asthma in this patient. Okay, so basically the main factor here that is 140/90 is the we have the hypertension is there, and the cause of hypertension here in this condition that is the renal disease. The history of bronchial asthma, this is just for you making you confusion. There is nothing about the history of bronchial asthma. This question they can ask you the simply also the patient blood BP is 140/90. So what is the most likely cause of hypertension in the given options? And the given option we having that is the renal disease. Okay, and this is all because of the retention of the sodium and the water due to improper kidney functions. Okay. This is the hygiene questions. If you see the light coefficient 1/5, so remember that is the discomfortable microclimate. The next one, the child is 11-month old. He suffers from nervous arthritic diathesis. The increased synthesis of what acid is pathogenic at nervous arthritic diathesis? The child is what? 11-month old and there is a nervous. What is the, firstly, what is the diathesis? The diathesis basically means we have the tendency to blood loss. Tendency to blood loss. So that is what our we having the diathesis. And it is what in simple if you make the definition, that will be the it is the inherited, means genetically, and there is a inherited disposition to nutrients and alternatives. Okay, no need to remember the definition, but that is what inherited dispositions to the nutrients and the alternatives. And what is the basically here in this for the crop to remember, the diathesis basically means we have the tendency to the blood loss. In this we will be having the neuroarthritic diathesis. The neuroarthritic diathesis basically means we will be having the some metabolic constitutional anomaly. Metabolic constitutional anomaly will be there. And this one will be caused by the disturbance of uric acid and purine metabolism. I hope you know already about the uric acid formation, how the uric acid formation will be there. This is the crop 1 we had discussed. In the crop 1 we had discussed about the uric acid. From the we having the adenine and the guanine will be there, and then they will make what? Hypoxanthine. And from the hypoxanthine there will the xanthine formation. With the help of xanthine oxidase, again the xanthine oxidase will be work as in the xanthine, and they will make what? Uric acid. If there is a more uric acid will be there, we call this as the gout as well. Okay, so if we will be having the disturbance of the uric acid and the purine metabolism, then we call this as the diathesis, as the neuroarthritic diathesis. Okay, so remember this, if it is associated with the uric acid, then this is known as the nervous arthritic diathesis, because the uric acid basically will be deposited in the joints regions, and it can be causing some kind of the encephalopathy as well. So that's why it will create the nervous, like neuro situations will be there, and the nervous arthritic diathesis will be there. Now we have the question. A 10-year-old child complained of the fever, frequent painful urinations, urine test, proteinuria will be there, leukocyturia will be there, bacteria will be there. What is the most probable diagnosis? So basically we have the 10-year-old child. So their patient is having the fever. The patient will be having the fever. Along with that, frequent painful urination, urine test, you will getting the proteinuria. WBC is there, like leukocyturia. Bacteria is there. So what is the most probable diagnosis? So that is, if you see the patient is having the fever, along with that you will see the WBC cast in the urine. You see the WBC cast in the urine. The most probably answer will be the pyelonephritis. Okay, if you see the patient is having the RBC cast in the urine, most probably answer will be the glomerulonephritis. Glomerulonephritis means you have the nephrotic and the nephritic syndrome. Okay, so basically if you see the patient is, because in pyelonephritis we will be having the fever will be there, and along with that you will see the WBC cast in urine, and the WBC cast in the urine along with the fever, it is the characteristics of what? Acute pyelonephritis. Okay, so let's discuss about the pyelonephritis. Pyelonephritis. Basically, see, we have in the pyelonephritis. Basically, this is associated with the nephrotic syndrome. So we will be having the hematogenous or we can say ascending infection or the descending infection. The ascending infection means that is starting from the urethra. From the urethra, after that it is going to the bladder, then it is going to the ureter, then it is going to the kidney, and then it is going to other organs as well. The same here, the pyelonephritis is also what ascending infection means it will occur secondary to the urinary tract infection, or we have the VUR, vesico-urethral reflex. We can be having the descending infection. The descending infection means like the infection that is starting from any other regions, but it's going on the kidney, going towards the kidney. Like for example, if the any infection that is starting in the lungs, but now it descending towards the kidney, so that will become the descending. But ascending means that is means secondary to the UTI. So that is what we call the ascending infection. So the pyelonephritis is what? That is the ascending infection. Or it can be the hematogenous. It can be the hematogenous infection. It will be the secondary to UTI, urinary tract infection, or vesico-urethral reflex, VUR. Vesico-urethral reflex. Okay. The pyelonephritis, now tell me, it should be common in male or female? And anyone tell me the reason? Female, right? Why female? Because the female have the shorter urethra. So, shorter urethra. That's why it is more common in the female because of the shorter urethra. And it is also common in children during puberty. Okay. And there will be the, because of the puberty, there can be having the less hygienic situations can be there, and there can be aware at the pregnancy, at the time of pregnancy. At the pregnancy also there is a high chances of the urinary tract infection. What is the most common organism that cause the pyelonephritis? Can anyone tell me what is the most common organism that cause pyelonephritis? Most common organisms causing pyelonephritis. That is Escherichia coli, E. coli. The E. coli is the most common organism that cause what? Acute pyelonephritis. What are the clinical features you are going to see in this patient? Let's suppose if the patients came with having the loin pain. The patients come with the loin pain, fever, burning, micturition. So these all are the characteristic feature of what? Pyelonephritis. Because there is a urinary tract infection, so the patients can be having what? Because of the infection, there will be the burning, micturition can be there. So the patient will be having the loin pain. The patients can be having the fever. The patient will be having the fever. Okay. And the patient will be having what? Burning, micturition. Burning, micturition. Okay, what is the loin pain? Basically, can anyone tell me what is the loin pain? Loin pain basically the region of the like lumbar region. Basically, the lumbar region, the pain will be in the lumbar regions on the back side, on the back lower side. Okay, so that is what the loin pain will be there. Along with that, you will see the very important feature in the urine. On the microscopy, if you will see, there is the WBC cast in the urine. When you will do the urine culture, so you will see the WBC cast in the urine. And along with that, you can also see the TLC level will be increased. The TLC level will be increased. Why the TLC level? Because of the infection. So you will see the most kind of the neutrophils will be there because of the infection. Okay. For confirmation, investigation you will do for investigation. You will do for imaging. What imaging? CECT, contrast enhanced CT scan. Contrast enhanced CT. CECT means we will add the contrast and then we will take the CT scan. So that is the CECT, and this is used for what? Confirmation of diagnosis. This is used for confirmation of diagnosis. Okay. And there is a one more feature is there that you have to remember, that CECT is the only scan that will help the pyelonephritis to differentiate it from the pyonephrosis. So it also help in differentiating it from pyonephrosis. Differentiating it from pyonephrosis. What is the pyonephrosis? The pyonephrosis is what? That is the pus filled regions. The pus filled regions or the pus filled kidney, you can say. The nephro means basically the kidney. So there will be the pyonephrosis will be there. Okay, is that clear? ठीक है, अभी तक everything is clear till now, guys. Okay. So after the pyelonephritis, there is a one more question in the test center, that is a xanthogranulomatous pyelonephritis. Okay, that is the xanthogranulomatous pyelonephritis. Xanthogranulomatous pyelonephritis. So what is the xanthogranulomatous pyelonephritis? Basically, it is the chronic form of the pyelonephritis. This is the chronic form of pyelonephritis. There is a different chronic pyelonephritis is also different, but this is like the one form that we are completely differentiating it into another type, that is the xanthogranulomatous, and there will be the distraction of what? Renal parenchyma. Renal parenchyma basically means like the all the structures, you can say, that is present cortex, medulla. So that is all what? Renal parenchyma. So there will be the distraction of the renal parenchyma. And normal kidney tissue in these conditions, normal kidney tissue will be replaced by granuloma, replaced with granuloma and lipid laden macrophage Okay, so it will give the yellow appearance. It will give the kidney will give us the yellow appearance because of the lipid structure. The lipids are what? They are the like yellowish in appearance. So that's why we call this the xantho. Xantho means something yellowish. Okay, xanthin pigment होता है ना, xanthin pigment is there that is looking like the yellowish. So that's why we give the name as the xantho. And a granuloma because there will be the granuloma will be there, and lipid laden macrophage that will give the yellow appearance. So these both will make what? Xanthogranulomatous pyelonephritis. But remember that in case no, usually what you see, the E. coli will cause the acute pyelonephritis. But here, if you see, it will be the most common bacteria that will be causing the xanthogranulomatous pyelonephritis, that is the Proteus, and then the second one is what? That is the E. coli. So remember that if we will be having the Proteus are there, okay, if there is a Proteus is there, so Proteus can also cause what? Acute pyelonephritis also. And so these are the some common things that you have to apply in the exam. So, and it is most common in the middle-aged females. This is most common in the middle-aged female and common in the diabetes. And these are the common in diabetes. Because of the diabetes, you can say the more sugar will be there, more cholesterol or the fats can be there in this patient. So that's why there can be the more common in this diabetic people. What is the cause of this? How it will cause? The cause, remember, whenever there will be the xanthogranulomatous, so there will be the, as it is the chronic form of the chronic pyelonephritis, so there will be the chronic obstruction of what? Urinary tract. There will be the chronic obstruction of urinary tract. There will be the chronic obstruction of the urinary tract, and there can be the recurrent UTI. Means urinary tract infections can be recurrent, or or basically UTI will be there, or it can be the due to diabetes mellitus, because the diabetes mellitus patient, they are more prone to the infections, you know, more prone to the infective agents, and they will be having the symptoms like the polyuria. So basically they will be creating the bacterial cell, and there will be the glucose. So bacteria, they love the glucose. So when there will be the glucose in the urine, so basically we will be having the more infection chances in the diabetes mellitus patients. Okay, let's suppose if you have done the investigations. The investigation you have done, that is the CECT. So in the CECT, what you will see? You will see there will be the non-functional kidney. The kidney is not working. Dum dum. So the non-functional kidney will be the non-functional kidney, and there will be the calculi. You will be see the calculi, and the calculi will be the stag-horn calculi. The stag-horn calculi, and they are the stool-white calculi. So they are the different type of the calculi will be there. You can search in the Google that the stag-horn calculi and the stool-white calculi. And one important thing that you are going to see here, that is the beer paw sign. The beer paw sign with enlarged kidney. With enlarged kidney. So all the questions of the xanthogranulomatous pyelonephritis, you will see this all this material in that question. The xantho, because the question, the framing will be different. It will be the 4 or 5 lines will be there. So basically you will see there will be the chronic form of the pyelonephritis. In the question they will add the calculi. In the question they will add the chronic obstruction. In the question they will give you the hint as the middle-aged female. In the question they will give you the some kind of the beer paw sign or the lipid-laden macrophage. Anything can be in the question, and you will understand that this is they are talking about what xanthogranulomatous pyelonephritis. Okay. After that, we will be having the chronic pyelonephritis. We will be having the chronic pyelonephritis. Chronic pyelonephritis. See, what is the chronic pyelonephritis? Basically, this is the complication. This is the complication of what? Acute pyelonephritis. Complication of acute pyelonephritis. Complication of acute pyelonephritis. Basically, what you are going to see here in this condition, there is the acute renal papillary necrosis. Acute renal papillary necrosis will be there. As it is the complication, so what will it will affect? It will affect the tubules, and once it will affect the tubules of the kidney, so there in this tubules of the kidney, you will see there will be the eosinophilic cast will be there. So till now I told you the RBC cast, WBC cast, and here I am telling you about the in the WBC we will be having the eosinophilic cast will be there. Okay, and this eosinophilic cast will be reappear as a thyroid tissue. It will reappear as the thyroid tissue, and it will cause the it is known as the thyroidization of kidney. Thyroidization of kidney. The kidney will be looking like the thyroid gland. Kidney will be looking like the thyroid gland. Kidney थायराइड ग्लैंड जैसी अगर हो जाए, मतलब किडनी के अंदर थायराइड ग्लैंड जैसे फीचर्स आ जाए, so that is known as the chronic pyelonephritis. So this is very peculiar feature of the chronic pyelonephritis, that in which condition you will see the thyroidization of the kidney, that is the chronic pyelonephritis. Okay. So this is basically we having the chronic pyelonephritis. The main thing that you have to remember about the chronic is that thyroidization. There is the tubules formation of the thyroid follicles will be there. They looks like the thyroid follicles, and that's why we will call that is a thyroidization of the kidney. So basically we would be having the acute pyelonephritis, xanthogranulomatous pyelonephritis, and we would be having the chronic pyelonephritis will be there. Okay, is that clear till now? Okay. After the pyelonephritis, there is one more disorder of the kidney, that is the GMN, glomerulonephritis. Glomerulonephritis. That is the glomerulonephritis. So basically, I told you already that if the patient is having the pyelonephritis, so there will be the WBC cost. That is the main hallmark of the pyelonephritis. But if we talk about the glomerulonephritis, the main hallmark here is what? That is the hematuria. That is what? Hematuria. That is hematuria. So the hematuria will be there. So hematuria, what is the blood in the urine? And that is the major hallmark. That is the hallmark of GMN. Panda baby has left the meeting. We have the hematuria. So the hematuria will be there. So we will be having on the gross examination. So in the gross examination, you will see what kind of the color? Cola color urine. Very Coca-Cola to that is that urine. And that is Coca-Cola. So that is the Coca-Cola colored urines. Then if you see about the microscopic examination. Microscopic examination. So in the microscopic examination, what you are going to see? There will be the more than 5 RBC per house filled unit. More than 5 RBC per house filled unit in centrifugal manner. You don't have to write, but just remember that we have the more than 5 RBC per household unit and more than 10 RBC per household unit in centripetal manner. Okay, so this is the when you do the microscopic examinations. So basically the gross examination, you will see the cola colored urine. Usually they will not give you the hematuria in the option in the question itself. They will write the patient is having the cola colored urine. Cola colored urine means the patient is having the hematuria. And the microscopic examination, if you do, then in that you will see the more than 5 RBC or more than 10 RBC in centrifugal and centripetal respectively. Okay. Now, what is the meaning of the glomerulonephritis? The glomerulus, you already know that we would be having the glomerulus. This structure is like that. This is what we have the glomerulus, the structure that is situated in the Bowman's capsule. So this glomerulonephritis, what is that? As the glomerulokidneitis, inflammation. So there is an inflammation of the glomerular. That is the inflammation of the glomerulus. And tell me, if there will be the glomerulus will be inflamed. So what will it do? It will impair the kidney function. It will impair the kidney function. And if it will impair the kidney function, it can lead to the kidney failure in the later stage. It can lead to the kidney failure in later stage. Okay, it can lead to the kidney failure in later stage. Okay, so that is what we have the inflammation of the glomerulus. So that means that glomerular capillaries that will become inflamed, and if that will become inflamed, that will impair what kidney functions, and that will lead to the kidney failure in the later stage. Okay, is that clear? So what is the basically if you talk about the further about the glomerulonephritis, so it can be the acute and the chronic as well. The glomerulonephritis, it can also be the acute and it can also be the chronic. In acute, there is the sudden onset of kidney inflammations, like it is basically due to streptococcal infection. But in the chronic, there will be the long-term inflammation. There will be the long-term inflammation. So if it is the chronic, because the long-term inflammation, it will gradually decrease the, or it will gradually it will damage the kidney. Gradually damage the kidney. And if if it will gradually damage the kidney, what will be there? There will be the CKD, means there will be the chronic kidney disease will be there. There will be the chronic kidney disease will be there. Okay. And in acute condition, there is the sudden onset. The sudden onset of kidney inflammation, and that is basically due to streptococcal infection. That is basically due to streptococcal infection. What the characteristic feature, if you say, the characteristic feature that you're going to see in this patient, these are what we having the RBC cast in the urine. There is the RBC cast in urine. There will be the dysmorphic RBC. What is the dysmorphic RBC? Means we RBC having the different kind of the abnormal, like abnormal shape. So that will be around more than 20% dysmorphic RBC will be there. The patient will be having mild proteinuria. We will discuss like in there are the two conditions, nephrotic and the nephritic syndrome. So in the which condition we will see the more proteinuria, and in which condition we see the less proteinuria. Along with that, you will see the patient will be having the pedal edema or periorbital edema. There will be the pedal edema, or there can be the periorbital edema can be there in these patients. Okay. And there is one more region of the proteinuria. The proteinuria, if you know about the CROC one, in the proteinuria, when we say there will be the decrease of what proteins. There is a decrease of what protein. So there is a decrease which is the major abundant protein that is present in the blood. What is that? Major abundant protein present in the blood. Major abundant protein present in the blood.
Albumin.
Yeah, that is what albumin. Okay, tell me which is the major abundant protein present in body? If there is the decrease in the albumin, there will the decrease what? It will decrease oncotic pressure. It will decrease what? Oncotic pressure. And if the oncotic pressure will be decreased, that will lead to the edema in this patient. And also, if there is a decrease in the oncotic pressure and all, there will be the increase of the GFR. This is one of the cause of the proteinuria. Other cause, or you can say this is the cause of the edema also. And this is the cause of decrease oncotic pressure. This is the most abundant protein present in our body. That is the collagen. Okay, the collagen is the most abundant protein that is present in our body, and albumin is the most abundant protein present in our blood. Okay, the very important topic for all the exams. So that is the GMN, glomerulonephritis. So basically, we would be having the nephrotic, and we would be having the nephritic. Okay. So the nephrotic, basically we would be having the massive. So firstly, you can remember it like that, in the nephrotic syndrome, we will be having the nephrotic. So what is that? Oh, so everything is what? Oh my God. What is that? Everything in the nephrotic syndrome, you can remember. Oh my God. So, oh my God situation will be there. In which condition? Nephrotic syndrome. And like suppose we would be having there will be the massive proteinuria. There will be everything will be the massive. So there will be the massive proteinuria will be there. And the massive proteinuria, like there will be the more than 3.5 gram per 24 hours. Means per day you will get the more than 3.5 gram proteins in urine. Okay. Along with that, you will see the patient will be having the lipiduria. You will see the patient will be having the lipiduria, and there will be the hypoalbuminemia. Means hypoalbumin means there is a decrease of albumin level, and the patient due to decrease albumin decrease, there will be the edema will be there. So the patient will be having a massive, everything will become massive. But albumin, you know that if the proteinuria is becoming massive, so the albumin level will be decreased, and that will lead to the edema. There is a very one important factor that you can forget every time. So that is what? That is a one thrombotic event. Thrombotic event. There is a one thrombotic event that occurs in nephrotic syndrome. What is that? Antithrombin antithrombin 3 in urine. What it will do? It prevents what? Clots. So that will be released in the urine. Okay. So what you have to remember here? There is the massive proteinuria, lipiduria, hypoalbuminemia, and edema. So these you will remember. One thing you will forget that you have to revise. So what is that? One thrombotic event that occur in the nephrotic syndrome. What is that? There will the antithrombin 3 in urine will be released. So antithrombin 3, what it will do? It will prevent what? Clots. It prevent what? Prevent clots. Okay. After that, let's suppose we have the next one, and the next one we would be having, that is the nephritic syndrome. When we say about the nephritic syndrome, so in the nephritic syndrome, in nephrotic we have the massive proteinuria. So in the nephritic we will be having the mild proteinuria. There will be the mild proteinuria. What is the mild proteinuria? Less than 1 gram per 24 hour in urine. And what was the nephrotic? Nephrotic was the, oh my god. And what is the nephritic? Nephritic, ho, ha. What do you have to remember? Ho, ha. Oh my god, ho, ha. So ho, ha. That is hypertension. That is means hypertension you are going to see. You are going to see oliguria. You are going to see the oliguria. You are going to see the hematuria. And if the hematuria, what kind of the urine? Cola colored urine. So basically, if I say that in the nephrotic syndrome, you will not get the hematuria, you can get. But more hematuria you will get in the nephritic syndromes. So in both conditions, you can get the hematuria, but this is the most characteristics of the nephritic syndrome. In the nephritic syndrome, it will be present, but in the nephrotic, it can be present, it cannot be present. Okay? And there is the azotemia. What is the azotemia? Increase blood urea nitrogen. Okay, that one will be increased. Okay, so just remember what? Oh my god, ho ha. Oh my god, ho ha. Oh my god, ho ha. So that is what we have the nephrotic and the nephritic syndrome. Okay. Now I think let's take a little break, right? After that we will discuss. Okay, just write the name. Okay, write the example here. So example is what? MCD. We have the MCD. That is the minimal. That is the minimal change ditches. That is the minimal change ditches. And we have the MPGN. That is membrane proliferative glomerulonephritis. Then we have the MGN, membranous glomerulonephritis. Then we can be having the FSGN. The FSGN means focal streptococcal glomerulonephritis. So this is basically MF 3MF. You can remember the 3MF. 3MF means we have the MCD, PGN, MGN, and FSGN. So we are having the 3M are there. 3M means we have the minimal change disease, membrane proliferative glomerulonephritis, membranous glomerulonephritis, and we have the focal streptococcal glomerulonephritis. And in case of the nephritic, we have the Burgers disease. Burgers. So we had discussed the Burgers yesterday. Burgers is vasculitis, tau. Okay. We have the IgA. This is also known as IgA nephropathy. We have the RPGN, rapidly progressive glomerulonephritis. Rapidly progressive glomerulonephritis. Then we have the PSGN. So we have the one option was there about the PSGN, that the post streptococcal glomerulonephritis. Okay, so we have the first, second, and third. So these are the Burgers disease, RPGN, and PSGN. So these are the nephritic syndrome. All started with the M, like MCD, MPGN, MGN, and FSGN. Focal streptococcal glomerulonephritis. So these are the nephrotic syndrome. Okay. Okay, then let's take a little break. 10 minutes, it's okay, I think. Okay, after that we'll discuss the all these things, MCD, MPGN, MGN, and FSGN. Okay, rather take a 15 minute. Okay, I think 10 minutes is more than okay. Take a 10-minute break, and in the 2 minutes, revise 2 to 3 minutes, revise whatever we have discussed. Revise not, we just read it. Read it what we have discussed till now, what I was teaching you. So check it out. So if it's all right or anything missing is okay, then we will discuss about the nephrotic and the nephritic syndrome. Okay. So because of the more proteinuria, we have discussed that there is a massive proteinuria will be there. So this is a oh my god situation, you can remember. So because of the more and more protein, you will see the frothy urine. Okay, here you will see the cola colored urine. But in case of the nephrotic syndrome, you will see the most usually frothy urine will be there. Frothy urine will be there in because of the protein and the presence of the fats, because the fats will be there and the protein, so they will give the frothy urine. Okay. Okay, so let's discuss the one by one. So the first we will be discussing that is the post-streptococcal glomerulonephritis. That is the post-streptococcal glomerulonephritis, GMN, post-streptococcal glomerulonephritis, or we call this as the PSGN. We call it pure. So this is also known as our acute proliferative glomerulonephritis. And the post-streptococcal glomerulonephritis, remember, this is the most common pediatric nephritic syndrome. This is the most common pediatric nephritic syndrome. This post-streptococcal glomerulonephritis, this is caused by group A beta hemolytic streptococcus, that is the GABHS. And the group A beta hemolytic streptococcus, remember, this is the Streptococcus pyogenes. This is the Streptococcus pyogenes. Okay. So remember, because this is very important one. This is one post-streptococcal glomerulonephritis. So this is also known as the acute proliferative glomerulonephritis, and this is the most common pediatric nephritic syndrome, and this is caused by the GAPHS, and incubation period, remember, it will be 1 to 4 week incubation period will be there. Basically, what we is going to see, the patient of the post-streptococcal glomerulonephritis, the patient will come with the complaint of sore throat or pharyngitis. Sore throat or pharyngitis. Now, after the sore throat or pharyngitis, the patient after 10 to 14 days, so you can see that this is the acute condition. Yeah. And this is proliferating, means sore throat and pharyngitis, it is proliferated to become what? It is proliferated to become the acute proliferative glomerulonephritis or the post-streptococcal glomerulonephritis, and you are going to see in this patient if the cola colored urine will be there. The cola colored urine after the 10 to 14 days, and that will lead to the hematuria, and that's why we call this as the nephritic syndrome. If we talk about the gross examinations, if we see there will be the gross examination. So in the gross examination, what you are going to see, there will be the flea beaten kidney. There will be the flea beaten kidney will be there on gross examination. The flea beaten kidney, like say this is what kidney, and the kidney you will see there is a very pinpoint hemorrhage, and this will be looking like the flea beaten. So that's why we will see pinpoint hemorrhage. Pinpoint hemorrhage will be there, going to see in case of what? PSGN. Okay, and microscopically, what you are going to see? You are going to see the starry sky appearance. You can see here that in microscopically, it will give the appearance as the starry sky appearance. So the starry sky appearance, this is seen in which condition? Tell me. Anyone speak out. What is the starry sky appearance is seen in which condition? Bolo, speak out with your vocal cords. Starry sky appearance will be seen in, अरे यही वाला भाई, this one. That is PSGN post streptococcal glomerulonephritis सामने है तुम्हारे, तुम्हें बोलना है, ठीक है? That is the PSGN. You have to speak out. ठीक है? And this is known as the immunofluorescence. On the immunofluorescence testing. The starry sky appearance, why it will be there? Some area they will be looking like very shiny area, and the some area will be looking very dark because of the pinpoint hemorrhage and because of the antigen antibody complex deposition. Okay, so remember that starry sky appearance, this is your one liner as well. Starry sky appearance is seen in PSGN, post-streptococcal glomerulonephritis. Along with that, the starry sky appearance is also seen in the Burkitt's lymphoma. Okay, you can write it somewhere. That starry sky appearance is also seen in the Burkitt's lymphoma, and one starry sky appearance is seen in post-streptococcal glomerulonephritis. Okay, is that clear? If you see the on electron microscopy, in electron microscopy, you are going to see the subepithelial humps. You are going to see the subepithelial humps will be there. Basically, they will the dome-shaped appearance. These will give the dome-shaped appearance. So basically, in the question, you can get this type of the appearance. That in the question, they will give the patient is there having the sore throat, pharyngitis is there. On electron microscopy, you are getting some dome-shaped appearance feature or the characteristics of the subepithelial tissues. So that is, you can understand that there means all this should be the correlated. Everything will be correlated in the question. So you have to correlate accordingly. Okay, and the treatment, remember, this is the you don't have to treat this condition. This is the self-limiting disorder. Self-limiting disorder. Okay. After that, the next one we have the let's eat the burger. Okay. So yesterday we have eat the burger. Now today we will eat what? Burgers. So that is IgA nephropathy. The IgA nephropathy is what? That is the Buerger's disease. That is what? Buerger's disease. So Buerger's disease is what? That is the most common nephritic syndrome worldwide. This is the most common nephritic syndrome worldwide, and the most common nephritic syndrome in adults. This is the two condition. The one we have the most common nephritic syndrome in pediatric. So that is what our PHA, and the most common nephritic syndrome in adults is what? That is the Buerger's disease. And the cause is again same. That is the GABHS. Group A beta hemolytic streptococcus bacteria, or you can say Streptococcus pyogenes. This is the name of the bacteria. So in this patient will also come with a sore throat or pharyngitis, but after 3 to 4 days what you are going to see, there will be the recurrent hematuria, and this is basically you will be seen in the adult, and there will be the recurrent hematuria will be seen. Or microscopically what you are going to see, there will be the IgA, that is immunoglobulin A, will be deposited in the mesangial cell. Deposits in mesangial cell. Where do you see the mesangial cell? Dekho. You all know, I'm just making you the diagram in your mind. There is a afferent arteriole are there. Okay, everyone, afferent arteriole that will be coming, and that carrying the blood, and then it will making the glomerular capillaries, and then it will become the globulus. From here the efferent arteriole, A for entry and E for exit. E for exit. So this will take out the blood. So this is the efferent arteriole, and here we will make the globular. So below the globulus we have the here, that is the Bowman's capsule will be there, and the Bowman capsule will surround what? It will surround what? Globulus. Between these glomerular capillaries we will be having some kind of the mesangial cell. So they are mesangial cell, they will present between glomerular capillaries. They are present between the glomerular capillaries. Okay, is that clear? Okay. And also remember, we will be having some kind of the complication. The complication that we are going to see here, that it can progress to RPGN, rapidly progressive glomerulonephritis. Okay, it can progress to the RPGN. Okay, after the next one we will be having the RPGN. So what is the RPGN? What we are going to see in here, that is rapidly progressive glomerulonephritis. So this is the third nephritic syndrome, and what you are going to see here, this is also known as the crescentic glomerulonephritis. It can be boring for you because it will becomes first again RPGN, PSGN, and so it can be little bit boring. But once you will able to revise this, it will be crystal and clear to you. Okay, so the rapidly progressive glomerulonephritis, this is also known as the crescentic glomerulonephritis, and we would be called this is because of half moon like structure. Crescentic basically means half moon like structure. So the kidney will becomes like half moon. So that's why we will be having the crescentic glomerulonephritis. What you're going to see in the here, you will see the fibrin, you will see the leukocytes, and the parietal cell will be more than the visceral cell. Parietal cell will be more than the visceral cell. All the vascular organs, they will be having the one parietal cell and one visceral layers. Okay, the parietal layer that will be present outside, and the visceral layer that is present or that will line the organ. So based on that we have the cell as well. There are the parietal cell and the visceral cell. Then RPGN we have the more what parietal cell will be there. Okay, you can easily remember with the help of flap. You can easily remember this with the help of a mnemonic, that is the flap. F for fibrin, L for leukocyte, and P for we have the more parietal cell will be there. Okay. And also remember on electron microscopy, you can remember that in RPGN we will be having the 3R will be there. 3R will be there. 3R basically we have the R for RPGN. In RPGN electron microscopy, you are going to see the rupture of basement membrane. There will be the rupture of basement membrane, and there will be the wrinkling of basement membrane. So you can remember with the help of RRR. Okay, that is very importantly that you have to remember. After that we have the, if we talk about the type,
Can you repeat the last R?
last R is the wrinkling, so WR. So this is, you can take it the small w and capital R. So wrinkling of the basement membrane is known as the RRR. Okay, I'm repeating it. See, RPGN, rapidly progressive glomerulonephritis. So this is also known as the crescentic glomerulonephritis, half moon-like structure. So clinically, we will see there will the fibrin will be there, the leukocytes will be there, and the parietal cells will be more than the visceral cell. On electron microscopy, in RPGN, what you are going to see, as there will the crescentic kidney will be there, or the crescentic glomerulonephritis. So there will be the wrinkling of the basement membrane as well, and the rupture of basement membrane will be seen in case of the RPGN. Now, if we talk about the RPGN, there is a three types will be there. We have the RPGN1, we have the RPGN2, and we have the RPGN3. And this is what, that is the most common. RPGN3 is the most common, and it include what? Microscopic polyangiitis. Microscopic polyangiitis. And it include the Wagner's granulomatosis. So remember, what are these? So these are the vasculitis. So RPGN3 include the small vessel vasculitis, that is the microscopic polyangiitis, and we have the Wagner's granulomatosis. The RPGN1 include the again vasculitis. Which vasculitis? That is a good pasture syndrome. Good pasture syndrome. Okay, so you can easily remember with the help of mnemonic 1, 2, 3, 4. 1, 2, 3, 4. So 1 means you have the RPGN1. So this is the RPGN1. Then hypersensitivity 2. Hypersensitivity, this example of good pasture syndrome is an example of, do you know what the good pasture syndrome, what is the example of the type 2 hypersensitivity? Bolo, what is the example of type 2 hypersensitivity? Good pasture syndrome. So in this we have discussed that basement membrane is affected, right? So the basement membrane, here I wrote here already that in RPGN we have the basement membrane will be affected. Okay, now it's become crystal clear that the good pasture syndrome, there is a hypersensitivity 2 and RPGN1, and it will be, there will be the basement membrane will be affected, and here there will the alpha 3 chain of collagen 4. Alpha 3 chain of collagen 4 will be affected. So that's why 1, 2, 3, 4. Okay, there will be the antibodies will be formed against that. Antibodies formed against alpha 3 chain of collagen 4. Okay, and there will be the good partial syndrome. I told you that it will be basement membrane will be affected, and the basement membrane will be affected if the affect the lungs basement membrane will be affected. So in that condition you will see the patient will be having the hemoptysis. There will be the bleeding, blood in vomiting, and if it will affect what, kidney, if it affect the kidney basement membrane, then this is cause the hematuria. This will cause the hematuria. Okay, then we have the RPGN2. The RPGN2, we have the RPGN, we have the post-streptococcal glomerulonephritis, because that will be progressive to the RPGN2, and it also include the SLE, systemic lupus erythematosus, and it also include the HSP, hinox pollen purpura. That's also a type of what, of RPGN2.
Sir, one more time, can you explain RPGN2?
RPGN2, it includes the like SLE, systemic lupus erythematosus. We have the post-streptococcal glomerulonephritis, and that will be progress to become the RPGN2. And we have the SLE and we have the HSP. So all this comes under the RPGN2 category. Okay. And we have the good pasture syndrome. So along with the good pasture syndrome, you also heard about the one more syndrome. There is a Alport syndrome. So in Alport syndrome, remember, there will be the, okay, write it anywhere, make a, so Alport syndrome, basically what will be there? There will be the alpha 5 chain of collagen 4 will be affected. Alpha 5 chain of collagen 4 will be affected. In case of the GPS, there will be the alpha 3 chain of collagen 4 is affected. But in Alports, remember, there will be the alpha 5 chain of collagen 4 will be affected. And in Alport syndrome, there will be the affected eyes will be there. Eyes will be affected. There will be ears will be affected. There will be the kidney will be affected. Okay, the eyes, the lens, in the eyes, the lens will be there. The anterior lenticonus. Anterior lenticonus means the lens will be falling anteriorly. So there will be the anterior lenticonus. The anterior lenticonus means lens will be falling, bulge, or you can say not falling, lens will bulge out anteriorly. So that is the anterior lenticonus. And in as ears, you will see the sensorineural hearing loss. If you know that in we have the two type of the hearing loss. One we have the sensorineural hearing loss, and one we have the conducting hearing loss. Okay, so in Alport we have the sensorineural hearing loss will be there, and the kidney, that is the most commonly affected, and there will be the basket wave pattern of basement membrane. Basket wave pattern of basement membrane. Okay, is that clear? So remember that Alport syndrome, we have the eye, ear, and the kidney will be affected. The eye, there will be the anterior lenticonus, we have the sensorineural hearing loss, and the kidney, we have the most commonly affected, that is the basket, and there will be the appearance will be given that the basket wave pattern of the basement membrane will be seen in the kidney. Okay, is that clear? Okay, just then we have the 5 minutes, we have the, and we will finish it. Then we will be having the about the nephrotic syndrome. In the nephrotic syndrome, we will discuss about the minimal change disease, and we will discuss about the FSGN. What do you wanted to in the next class? That's it, because
Sir, finish it today, sir.
So we will be having the nephrotic. So in the nephrotic, we will be having the first one, that is the minimal change disease. That is the minimal change disease. The minimal change disease is the most common nephrotic syndrome in child. Most common in the children. Okay, so you can remember the mini. Mini means children. Mini, chotu chotu, mini, chillu chillu, child. Okay, so that a cause is what? The cause I don't know. What is this answer? This is the idiopathic answer. I don't know. So this means this is what? Idiopathic. This is what? Idiopathic. The minimal change disease, this is also known as lipid nephrosis. Why we call this as the lipid nephrosis? Because there will be the lipid in PCT, means proximal convoluted tubules. That's why we call this as the lipid nephrosis, and this is also known as nil deposit disease. Nil deposit disease, because nothing has been deposited and the immunofluorescence will be negative. Write it full form: immunofluorescence. Immunofluorescence will be negative. Immunofluorescence will be negative. Okay. The most characteristic feature that you are going to see on electron microscopy, what is that? There will be the foot process. The foot process will be there, or like we call that the podocytes. Okay, all the if that will become flattened. So that is flat means we have the effacement. So this is known as the effacement of the foot process. And these are foot process. These are known as the podocytes. Okay, and this is the gold standard characteristic feature that you are going to see in the minimal change disease. Okay, along with that, what you are going to see in the patient with the minimal change disease, there will be the selective proteinuria, and there will be the hyaline and fatty cast will be there. Hyaline and fatty cast in urine will be there. Hyaline and fatty cast in the urine. So basically, what you are going to see in the patient, देखो, in minimal change disease, this is the most common in the children, and the cause is what? That is the idiopathic. This is also known as what? Lipid nephrosis, the lipids in the PCT, and this is also known as the nil deposit disease. So immunofluorescence will be negative. Then what you are going to see in the electron microscopy, there will be the effacement of the foot process. Effacement means that will become flattened. And then the selective proteinuria, and we have the hyaline and fatty cast will be seen in the urine. And remember that for the treatment of minimal change disease will be the steroids. Okay, this is the thing that you have to remember for this one. The next one we would be having, that is the focal streptococcal glomerulonephritis. The focal streptococcal glomerulonephritis, or the focal segmental, basically. Focal, not streptococcal, focal segmental glomerulonephritis. This is the most common cause of nephrotic syndrome in adults. The most common nephrotic syndrome in adults. Okay, and the cause, remember that when we talk about the causes, there can be the HIV, hypertension, heroin, reflex nephropathy, and there can be the sickle cell anemia, renal tissue loss can be there. So they all are the causes that will cause the focal segmental glomerulonephritis. On if you do here, if you will do the main characteristic feature or the hallmark feature, you're going to see the patient will be having the focal segmental sclerosis. There will be the hyalinizations, means hyaline cast will be there where in glomulation of glomerular capillaries. So there will be the hyalinization of the glomuli, and there will be the lipid droplets will be there. There will be the lipid droplets will be there in case of the FSGN. Okay. So this is basically we have the focal segmental glomerulonephritis. So focal segmental glomerulonephritis basically is the most common cause of the nephrotic syndrome in the adults. And you are going to see there will be the focal segmental sclerosis. The glomeruli will become hyalinization. There is the hyalinization of the glomeruli, and there will be the lipid droplets will be there. The main in the nephrotic syndrome that you have to remember is the about the minimal change disease. And all the nephritic syndrome is also very important. That we have the RPGN, that 1, 2, 3. One second, we are right. This is basically focal segmental. Okay, so this is basically we have the FSGN, we have the focal segmental, and after that we will be having the third one, that is the MGN, membranous glomerulonephropathy. So remember that if you're talking about the membranous glomerulonephropathy, this is most commonly you are going to see in the elderly patient. The most common in the elderly patient. And this is the form of chronic immune complex, mediated disease. Okay, now if you say that if you're talking about the MGN, there will be the primary MGN or there can be the secondary MGN. And in primary, basically there will be the antibodies formation. Basically there will be the immune complex mediated will be there. And the secondary MGN is because of another region, like another cause will be the secondary. The cause will be secondary means we have the drugs can be there, like NSAID, penicillamine, or it can be due to gold. And infections like HBC, HCV, and syphilis, malaria, leprosy, all they can cause the membranous glomerulonephropathy. So it can be the primary due to immune system, immune or the antibodies formations. Like antibodies will be formed against the phospholipase-A2 receptors and CD10 receptors. So that will be going the primary. And the secondary will be due to like drugs, or it can be due to some infection. The drugs like we have the penicillamine. With the penicillamine, gold, NSAID, and infection like we would be having that is the HBV, HCV, syphilis, and malaria and leprosy. So all they can cause the minimal change disease. And remember that when we see the microscopically, so the microscopically that is very important characteristic feature. If you see the spike and dome pattern from basement membrane, like if you see spike, dome, spike, dome, spike, dome, spike, dome. So this kind of appearance, if you're going to see, that means this is what? This is MP, and this is the membranous glomerulonephropathy. Okay, and along with that, if you see the on electron microscopy, there will be the subepithelial deposition. The main thing that you have to remember here, there is the spike and dome pattern. Hanji.
Sir, after malaria, is that leprosy?
After the malaria, there is a leprosy. Okay, then electron microscopy, you are going to see the subepithelial deposition will be there. The same like we have the membranous proliferative glomerulopathy or the membranous proliferative glomerulonephritis. So again, this is the two types. We have the MPGN. These are not so much important. That's why I'm going little fast here. The MPGN1 or the MPGN2. The MPGN1, basically you are seeing the you saw the tram track appearance. Tram track appearance. So the tram track appearance will be seen in MPGN1. Okay, in this basically the basement membrane will be divided into the two parts. Okay, you can write it here. Basement membrane. BM means basement membrane divided into two parts, and they will be the subendothelial deposits. They will the subendothelial deposits will be there. The MPGN2, they will be the persistent hypocomplementemia. Means complement level will be decreased. So there is the decrease in the hypocomplement. But in MPGN, there will be the deposition, intramembranous deposition will be there. Intramembranous deposit, and that's why we call this as that's why it also known as dense deposit tissue. Whatever the fibers, whatever the fibrins, whatever the all those deposition will be in the intramembranous, and this is also known as the dense deposit disease. Okay, so this is about our nephrotic and the nephritic syndrome. Okay, then yesterday we will discuss about the cystitis and the little bit about the acute interstitial nephritis and then acute tubular necrosis. There are some or other disorders related to the kidney and our urinary infections. Is that clear till now?